Hello, everyone, and welcome to our 7th virtual amyloidosis support group meeting, our 4th for AL amyloidosis. All of our previous meetings can be seen on our website, amyloidosissupport.org, and also on our new YouTube channel. So if you haven't glanced at that yet, just go to YouTube and do a search for amyloidosis support groups, and you'll see it there. The nice thing about that is there's closed captioning. Now, this webinar should be available in a week or two up on both the YouTube channel and our website. As far as live meetings go, we hope to resume them in 2022, of course. And if things go really well, maybe a few towards the end of 2021. Stay tuned and we'll let everyone know when the next meeting is virtually and live. We always do on our website, in our Facebook groups, and our other social media contacts. We realize that the main thing lacking from these meetings, we have wonderful doctors presenting and we have great physician participation, but we don't have the patient-to-patient contact. But you can achieve that by joining our Facebook groups if you're not already on them. We do urge you to join those. In the control room today, we have, again, ASG's Executive Director, Paula Schmidt.
Hey, everybody. Thanks for coming.
And our Special Projects Director, Bob Gibson.
Hello, group. I hope you have a great webinar today. I'm looking forward to it.
Okay. Now, you won't be able to post comments in the chat, but do pay attention because there'll be some important things posted in there, and Paula will be putting some links in there for financial aid, etc. We've received hours worth of questions today, and hopefully our panelists will be able to get to quite a few of them. But keep in mind that we will be sending the unanswered questions to our physicians for responses, and we will email them back to you on an individual basis. But all the questions that you emailed in have been seen and will be responded to one way or another by our physicians. And speaking of them, our presenters today are Dr. Morie Gertz from the Mayo Clinic. Dr. Gertz will also be acting as moderator for the abstracts and the Q&A session. Also joining us will be Dr. Anita D'Souza from the Medical College of Wisconsin. Those of you who come to our Chicago meetings are familiar with Dr. D'Souza for sure. Then we have Dr. Andrea Havasi, the nephrologist from Boston University. She also has been to many of our meetings. Dr. Chafic Karam from the University of Pennsylvania, our new resident neurologist. Everyone loves them, of course. Dr. Michaela Liedtke from Stanford Amyloidosis Center. She also has been a guest at some of our West Coast meetings. Dr. Mathew Maurer from Columbia. We wouldn't have a meeting talking about cardiology without Dr. Mathew Maurer, of course. And Dr. Agne Paner from Rush University Medical Center. She also comes to our local Chicago meetings. And Dr. Jeffrey Zonder from Karmanos Cancer Institute. And everyone knows Dr. Zonder, and also he tells me that he'll be updating our treatments for 2021 soon, the treatment chart that everyone loves. Other panelists joining us today are Dr. Jonathan Wall to give us an update on his imaging study, and Dr. Mike Royal, a newbie for us from Sorrento. He's going to be presenting a new trial for a drug similar to Daratumumab that they hope will help those who did not have a response to Daratumumab. Then we'll have a 10-minute break, followed by our first Q&A session. That one will be really interesting, right? We're going to have a brief survey that we ask all of you to fill out when the program ends, or if for some reason you have to leave before the program ends, please take a few minutes to fill out the survey. We really appreciate it, and we learn a lot from your responses. Okay, now let's hear from Dr. Gertz.
Thank you, Muriel. We're going to start out actually by quizzing our panelists about American Society of Hematology, December 2020, and some of the new reports on the management of amyloidosis. we're going to focus initially on the Andromeda study because it was such an important inroad into the management of this disease. Before we start with the Andromeda study, we want to discuss a little bit about some of the lead-in data that led to the development of Andromeda. And so Daratumumab, which is trade name Darzalex, but we'll refer to it by its generic Daratumumab, was reported early on by Dr. Liedtke at Stanford. And I'd like Dr. Liedtke to discuss, if she would, a little bit first introductory about how Daratumumab, Darzalex, works, why she selected it as a treatment for previously treated amyloid, and some of the early outcomes she's seen. So Dr. Liedtke, if you would, please.
I'd be delighted to. Daratumumab is a monoclonal antibody. It binds to a surface antigen on the plasma cells that's called CD38. And it works by a lot of different mechanisms. It recruits other immune cells to destroy the cells. It also cross-links the CD38 antigen, and in the process of that induces cell death of the plasma cells. It's very well tolerated. It's given as an intravenous infusion, at least in the beginning. Subsequently, there's now a subcutaneous version of the drug. It's given once a week, initially for 8 weeks, and then every other week for 8 doses, and then once a month. And it was originally approved for treatment of relapsed or refractory multiple myeloma. And we saw that in that group of patients works really well. And so it was an easy step to take to think about using it in our patients with light chain amyloidosis. And I still remember the very first patient we treated. He's actually probably someone that you all familiar with, or at least some of you. It was a patient who had presented with severe cardiac involvement and had undergone an orthotopic heart transplant for his disease. We had been able to control his light chains relatively well, but not into a complete remission. And so decided after the heart transplant to do a stem cell transplant, which resulted in further light chain reduction, but not a complete remission. So over the course of the ensuing years, we tried multiple different combinations, including lenalidomide and pomalidomide and carfilzomib, and every drug helped somewhat, but none of the combinations were able to achieve a complete remission. And so this was the first patient we gave daratumumab to at Stanford. And after just 2 weeks of therapy, we checked the light chains and they had completely normalized. So it was really like magic for the patient and for us to see that we were finally able to control his disease. And subsequently, we treated more patients, with daratumumab. And this was not a clinical trial. What we reported on is a retrospective series. But what we found is that very heavily pretreated patients were able to achieve responses. Almost every individual patient of the group that we treated had some reduction in their light chain burden, but about 3/4 had what we would call a response, which means a reduction of the differential of the free light chains of at least 50%. And about 1/3 of patients achieved a complete remission with normal light chain levels and a negative SPI and UPI. So we were very impressed with the drugs. And of course, we weren't the only ones. There were other groups around the world who used daratumumab as well and observed similar findings.
Thank you very much. Dr. Paner, in terms of the Daratumumab administration that Dr. Liedtke used and the Daratumumab administration that was used in the trial, the preparations were different. Can you talk a little bit about the two regimens that are associated with the Daratumumab and how they differ in terms of their administration and side effects and why one would select one over the other?
So Daratumumab initially was investigated as an intravenous agent, and the infusion was very long. The first infusion had to be given almost over 8 hours. It partly depended on patient's body weight. Subsequent infusions could be given at half of that time. Now, sub-Q administration has really been a big game changer with Daratumumab. The current formulation that was actually also used in Andromeda study is Daratumumab Fast-Pro. It's given as a 5-minute infusion under the skin. And with the first infusion, patients have to be observed for 3 to 4 hours for possible infusion. But afterwards, it's really a quick trip to infusion center. And in multiple myeloma, subcutaneous administration of daratumumab has pretty much replaced intravenous use. And we see that in amyloidosis as well. I think what was somewhat concerning with subQ administrations, patients with amyloidosis can have an ASARCA, and is the absorption of drug as good? And it seems like patients do have good absorption with subcutaneous administration.
I'm sorry, what's on ASARCA?
Yes, thank you. I should use more understandable terms. So an ASARCA is a diffuse swelling. Patients with amyloidosis who lose a lot of protein in their urine tend to swell. And many times that swelling is going to be not only in the legs, but can extend into waistline, where typically those injections are given.
And so you've given up on intravenous daratumumab.
That is correct. In our institution, we only use subcutaneous daratumumab.
Thank you very much, Dr. Zonder. So now we've got subcutaneous daratumumab, and we've got this preliminary information about its high level of activity. Can you give us the nuts and bolts of the Andromeda trial, please?
Sure. So the Andromeda trial was a randomized study using a standard backbone regimen called CyBorD, which is cyclophosphamide, bortezomib, which is Velcade, and dexamethasone. And that was given in repeating cycles, 6 cycles, and then I believe 6 cycles, and then randomization to the addition of daratumumab or not. And the daratumumab in this trial was subcutaneous, and it was administered from the outset and then was continued as maintenance therapy after the CyBorD in the group of patients that were randomized to the daratumumab arm. The group that got just CyBorD, which is standard of care, did not get any sort of maintenance therapy. So there was, when the addition of daratumumab, it was not just that an extra drug was added initially, but it was also, therapy was extended significantly compared to patients who did not get that.
And what was found?
So what was found was that the addition of daratumumab dramatically increased the likelihood of achieving deep hematologic responses. And that increase in higher hematologic control, reduction in the amyloid forming light chain, translated into higher rates of organ responses also. And so we saw much higher likelihood of both cardiac and renal responses in the patients who had heart and kidney involvement by amyloidosis. And all of this was done after a safety run-in trial demonstrating that you could safely combine daratumumab with CyBorD chemotherapy.
Thank you. Dr. D'Souza, so just before we go forward, can you again break down what we're talking about? What does it mean, hematologic response and deep hematologic response? I mean, when my doctor tells me that, what are we talking about?
Sure. So in AL amyloidosis, we have 2 things happening at the same time, right? So we have a cancer that's growing in the bone marrow, and the product of these cancer cells, the free light chains, are what are turning into these sticky insoluble fibrils that are causing organ damage. So when we treat, now the ideal treatment would be a chemotherapy drug that works at the bone marrow level, and something that works at the organ level that will salvage or protect the organs. Unfortunately, we don't have fibril-directed therapies that are ready for prime time yet. So we are dependent entirely on really rapidly effective chemotherapy drugs. And our goal when we start chemotherapy treatment in AL is to bring down the free light chains, particularly that involved free light chain, the one that is turning into amyloid fibrils, back to as low of a level as we can. And not just as low, but also very rapidly. So if we can do it within the first month, we know that those are the patients who have the best likelihood of having organ response, so getting their hearts, their kidneys back into normal function. So what Andromeda study showed was that no matter how we diced the results, what measures, what criteria we used, it was the patients who got daratumumab along with the Cyborg-D regimen that quickly got their free light chains, that difference in the involved and the uninvolved free light chain down to less than 40, but also the involved free light chain down under 20 milligram per liter.
Units, please.
Milligram per liter. So if we look at it as milligram per deciliter, remember to take away a zero. So it's either 4 milligram per deciliter or the involved free light chain under 2 milligram per deciliter. And if your lab measures it in milligram per liter, then it's 40 or 20.
Thank you. Dr. Liedtke, with these remarkable results, is stem cell transplant dead for amyloid?
I don't think that it's dead, but I think that it's definitely going to be used a lot less. I mean, I think, remember that, like Dr. D'Souza said, we want to achieve rapid responses and deep responses, but we also want them to last very long. And stem cell transplant may still have a role in a consolidative way in keeping patients in remission for a long time. But I would definitely predict that we will use stem cell transplant less and less going forward as our other therapies are becoming more effective.
Dr. D'Souza, in terms of the American Bone Marrow Transplant Registry, are you seeing a decline in the number of amyloid transplants coming into your data files?
Not yet. We just looked at those numbers to try and understand how Andromeda might have changed that. We still see about close to 300, 250 to 300 stem cell transplants being done in amyloidosis in the United States. But I think as now that the regimen is FDA approved, the coming years might show a decline, but we haven't seen it as of yet. I think one thing to remember is that in patients who are transplant eligible, even if the intent changes not to do the stem cell transplant early, to have the stem cells collected so that if this is an option for the future, we have collected the stem cells within that first year of starting treatment.
Thank you. Dr. Zonder, you said that the daratumumab containing arm was superior. Can you put some numbers on those responses? How much it increased the response rate now that we know what a response is?
I can. I can find the exact numbers for you. It increased the complete hematologic response rate from something like 18% to about 53%. If you use the definition. It tripled it, and really there were multiple different variations on deep hematologic response explored in the study. They looked at difference in free light chain. They looked at absolute reduction in the involved free light chain. They looked at the definition of complete hematologic response as originally used in the protocol, and all of them were dramatically enhanced by the addition of daratumumab, and all of them also actually predicted improved outcomes. So no matter which definition of deep response you used, all of them were helpful, predictive of good outcome.
Dr. Maurer, there was also a second presentation on Andromeda about the outcomes by cardiac stage. And so what I'd like to ask you to discuss are three things. Number one, what the heck is staging in amyloid? I want to understand the stages. And Dr. Zonder talked about cardiac response, and I'd like to understand what a cardiac response is, and then tell me about what the outcomes were by cardiac stage.
Yeah, so as people have indicated, AL amyloid is a disorder not only of the plasma cell, but its effect on the end organs. Most importantly, usually the heart and the kidney. We stage patients, I think, as most people know, based on a group of biomarkers that are utilized. These are blood tests, including troponin values and NT-proBNP typically, though there's a staging system that's been developed by the Boston Amyloid program based on BNP. And essentially, the higher your values of your BNP, the worse your heart is functioning, and the same for troponin. And so patients can be grouped into various stages: early, middle, late, and very late. Additionally, the staging system involves, at diagnosis, the difference between the involved and uninvolved light chain, and whether that's above 18 milligrams per deciliter. So, in general, a cardiac response is defined in patients who have an NT-proBNP above 600 picograms per ml. Most patients with AL amyloid do have a value above that, but for the rare patient who's below that value, a response really can't be defined by these criteria. But in general, if your NT-proBNP goes down by either 300 picograms per ml or more than 30%, whichever is greater. So you need to meet the criteria of greater than 30%. For example, if your NT-proBNP is, say 3,000 or some on, that would be considered a cardiac response. And in general, cardiac responses always follow the hematological response. We in cardiology rely heavily on our expert hematological consultants to use therapies such as Daratumumab to get the light chains down in order to affect a organ response, such as a cardiac response. And in general, in the Andromeda trial, as in other studies, organ responses were seen in a significant percentage of patients, much greater with Daratumumab than with standard therapy of Cyborg D. And in general, I would say that it's always better for a patient to be diagnosed early without advanced cardiac involvement, because prognosis is always better under those circumstances.
Muriel, you had a question.
I do. There seems to be some question and concern with our patients when they see that the Daratumumab was approved for newly diagnosed patients along with Cyborg D. So this is a kind of a two-part question. They're concerned that insurance will deny them the Daratumumab coverage if they are not newly diagnosed. They're also concerned that the insurance companies, a few of them say, no, you have to have it along with Cyborg D, and some of them don't want to have bortezomib, or their doctors don't want them to have bortezomib because of the neuropathy issue. So will there have to be another trial and a secondary approval by the FDA for previously diagnosed patients? Or will the insurance companies accept an off-label prescription of Daratumumab without Cyborg D, or Daratumumab with some other combination?
Dr. Liedtke, have you had issues in terms of reimbursement for Daratumumab in previously treated patients?
No, we've not run into issues with that. And I think one thing to remember is that even though we differentiate patients who have multiple myeloma from patients who have light chain amyloidosis, the underlying disease process is very similar. And the NCCN guidelines actually recognize the presence of light chain amyloidosis as a disease-defining criteria for multiple myeloma. And so that's specifically done so that we don't run into insurance issues.
There was a second question here. If I could ask you, Dr. Paner, this question about not giving bortezomib, but using a regimen that did not contain bortezomib or Velcade. Is that something you've been doing or are comfortable with?
Certainly. So Daratumumab was initially studied as a single agent in AL amyloidosis, and a lot of patients in the United States get treated with bortezomib in an upfront setting. So we cannot use at relapse if they've had major toxicities or they relapse fairly soon after that treatment. And in that case, using Daratumumab as a single agent is very reasonable. There is some emerging data about perhaps using it with lenalidomide. I'm not so concerned that the fact that this was approved for newly diagnosed patients will jeopardize. I think, on the contrary, if anything, it should help with getting approval in relapse setting.
Dr. D'Souza, this question about the nerve damage that occurs with bortezomib or Velcade, there was also a presentation at ASH on the combination of Excisomib, whose trade name is Ninlaro, cyclophosphamide and dexamethasone in untreated patients, a phase 3 trial. Could you discuss a little bit about your impressions on those results and where Excisomib fits into this treatment paradigm?
Sure. So Excisomib is a formulation that was FDA approved to treat relapsed multiple myeloma in around 2015. Actually, the approval for Excisomib came at the same time as Daratumumab. And in myeloma, we use it in patients who have relapsed disease. Now, the advantage of Excisomib is that it is an oral agent, so you don't have to go to the infusion center or to the hospital to get it, unlike Velcade or bortezomib. So in this trial, investigators from the Mayo Clinic replaced the Cybor-D, they replaced the bortezomib with Excisomib and created this all-oral regimen where all three medicines of the regimen are administered by mouth or orally, and found that it is an effective regimen, and it can be done with similar efficacy as the Cybor-D regimen. Now, in terms of neuropathy, while the neuropathy risk is a little lower with Excisomib, it can still cause neuropathy. So if I'm very concerned about worsening neuropathy in an amyloidosis patient who has pre-existing neuropathy, I'm still careful using either Velcade or Ninlaro or Excisomib. But this is a regimen, particularly as we got into the pandemic this past year, where there were a lot of concerns about having to come for weekly visits to the hospital or the cancer center. A regimen such as this can be administered and given to patients where they don't have to come as frequently to the hospital.
Thank you very much. Dr. Zonder, so we talked about one new agent, Excisomib or Ninlaro, as being effective. There were also presentations including another antibody, Isotoxumab. Can you tell me a little bit about what that is and some of the outcomes with what you would expect with the use of the medicine? Will it have a place in our management toolbox?
Right now what we have is a phase 2 study of Isotoxumab in amyloidosis. It is, in a nutshell, a different anti-CD38 antibody than Daratumumab. So it doesn't bind CD38 exactly the same way, but the target is the same. And I think predictably, it had an impressive single agent response rate in phase 2, in this phase 2 study. What we don't really have so far in amyloidosis, at least, is any sort of combination data. It has some, sort of disadvantages right now in terms of its positioning. It's far second out of the gate, compared to Daratumumab. So Daratumumab is a drug that people are familiar with. It also doesn't have a subcutaneous version. One of the advantages of it originally was that it could be given quickly compared to IV Dara, but it's not quick compared to sub-Q Dara. And so it's hard to know if it's going to have much traction. It definitely has activity. It remains to be seen how it will be developed, or if it'll be developed in amyloidosis. But I suspect that it will be a potentially usable drug, both as a single agent and also potentially as a combination. In multiple myeloma, It's actually approved in combination with pomalidomide, and can be combined with other standard myeloma drugs. So that may well be how it ends up being used in amyloidosis.
Dr. Maurer, if I have stage 2 amyloidosis and I get treated, can I go to stage 1?
Absolutely. Yep, that's the goal. Make the heart better.
And
So-
what about in terms of not the New York Heart Association cardiac stage, but in terms of the diagnostic staging that you talked about with the biomarkers?
Yeah, so both can improve, right? I mean, the goal is feel better, live longer. So it's quite possible and quite likely that if your light chains are controlled, that your amyloid stage would improve. That is, your biomarkers would decline. Light chains are down, NT-proBNP is down, troponin is improving, God willing, normal. And concomitant with that, there would be an improvement in your functional capacity. And so clinicians would rate your New York Heart class, which is based on patient self-report of what they're able to do, as improving, moving from 3 to 2 to 1.
Dr. Paner, in terms of the side effects of this Andromeda regimen, what are the medicines that you think have the worst side effects and need to be modified most often?
Well, I would say that's steroids. It's probably one of the oldest.
Which are the steroids?
Dexamethasone. In the study, it was the dexamethasone that was used. It's a drug that can cause swelling in the legs, which is a lot of times a problem as it is to the patients, whether they have renal or cardiac involvement, if their albumin is low. It's also a drug that is hard for elder patients to tolerate because it may keep them up at night and cause some agitation. If patients are prone to diabetes or hypertension, those things can get worse. A second drug I would say would be bortezomib or Velcade, and that's mostly because of the peripheral neuropathy, which typically doesn't happen right away, but it happens towards cycle 3 to 5, but it can sometimes happen right away. Velcade can also give GI toxicity, especially in patients with autonomic dysfunction and GI involvement who already suffer from nausea, indigestion, and bloating. And I would say that daratumumab is probably the best tolerated of all these medications and added very little toxicity in Andromeda study. The main concern was infusion reactions, and those typically, if they're going to happen with the first infusion, and afterwards they're very unlikely to happen. And also slightly increased risk of upper respiratory infections. As it brings down cancerous plasma cells, it brings down also good plasma cells, and there is a slight increase in infections. Although I have to say, during this COVID pandemic, with all the mask wearing and social distancing, I'm enjoying seeing so much less upper respiratory infections all around.
Thank you. Dr. D'Souza, these results that are reported in the trial, will these be applicable to the real world in every amyloidosis patient we see?
So one thing to keep in mind is that Andromeda study excluded patients who had the most advanced cardiac amyloidosis. So these were patients whose NT-proBNP levels were greater than 8,500, or they had the New York Heart Association classification of 3B or 4 heart failure, or their blood pressures were, systolic blood pressure was less than 90. So that's the one caution, is that at this time, until we have further data, that group of patients, and indeed that's the group of patients where we need to have the quickest responses, hematologic responses. But unfortunately, Andromeda doesn't answer that.
What about kidney?
So in terms of renal involvement, I believe this trial excluded, although I don't have the
30.
was it 30? Yeah. So patients who had chronic kidney disease below stage 3 or higher were also excluded. So again, I think that's the problem with clinical trials, is that we are selecting the best players or patients who are likely to do well. But in the real world, we have to treat everyone. And a lot of amyloid patients do present with renal disease as well as advanced cardiac amyloidosis.
Sorry, it was 20, but your point is well taken. Dr. Zonder, I have stage 2 disease. Can you tell me how long I'm going to live?
Well, short answer, no. What cardiac staging is basically is it puts you in a lane. It's a way of assigning prognosis from the time of diagnosis, but it does not guarantee how you're going to do. It sort of predicts how groups of patients with similar degrees of heart involvement do over time. And so, the goal is to be the last person off whatever survival curve you are on, right? That your stage would predict. And, and it is possible to affect survival. We know that even in the toughest patients, even patients diagnosed with stage 3B cardiac disease, can have their average survival improved if they get a fast, deep light chain response. The European investigators, the British group particularly, has really done a lot of work teasing that apart, and it is possible to impact prognosis in any subset of cardiac patients, although it's hardest to do it in the most advanced patients.
So no matter what stage I am, is there an upper limit to my survival?
So I would say for the majority of patients, well, the short answer is no. I mean, the short answer is the difference in survival, and then I'd welcome people's opinions, and certainly the survival curves are very, very different for different cardiac stages, especially cardiac 3B. But the differences in survival between different cardiac stages really mostly is what happens in the first year, or approximately first year, and it's related to the risk of having a cardiac complication as a result of damage sort of already done. And I always sort of emphasize to patients that the survival curves, all of them, are kind of two stages. There's a initial part of the survival curve, and that's steeper for patients with more advanced cardiac disease. But after that, if you manage to sort of weave through that first year, and at the end of the first 6 to 12 months, if you have if you've emerged in the midst of a great hematologic response, your survival after that is actually pretty good. And when you look at the survival curves for stage 1, 2, and 3 patients going forward from, say, that 12-month mark, patients with good hematologic control actually do similarly.
Thank you.
In terms of survival after that.
Dr. Liedtke, I want to talk a little bit more about the staging business and how applicable it is. And when doctors are talking about stage, so I just want to give you this hypothetical that at Mayo Clinic, we reported much, much better survival of our patients than at Stanford. It was a lot better. And then you read the publication, and what you saw is that 80% of the patients seen at Mayo are stage 1. And at Stanford, 20% of the patients are stage 1, and the remaining are much higher stages. So can you tell me how health professionals use stages to kind of interpret data, results, therapies?
Yeah, I think this highlights the difficulty in comparing reports from different institutions when there's single institution analyses, because and the same is true for clinical trials too. It always depends on which particular population you're analyzing. I think what we all know is that what Dr. Zonder said, and I echo that, that patients with very advanced cardiac disease certainly have a worse prognosis. We can never really predict the prognosis for one individual patient. So I don't think that the survival for any individual patient should ever be considered limited, and we will always try the best we can to treat patients. The other thing to keep in mind when we look at these analyses is, in order for us to perform a survival analysis, by definition, we always go backwards and looking at patients who were treated 10 years ago or 5 years ago. And with rapid advances in the field, these numbers will always change. And the numbers that an actual patient today can expect are always better than what's reported in the literature, because we always, by definition, report older data that's not including those new advances that have been achieved.
So looking at those results tell me nothing about how I'm going to do now.
Exactly. I think it gives you, maybe a sense of patients with advanced stage disease doing worse and needing our attention more and needing deeper responses faster, and potentially in the future needing amyloid fibril targeting agents more than patients with an earlier stage disease. But at the same time, I think it doesn't necessarily mean for each individual patient that they will do exactly like it said in the survival data.
Dr. D'Souza, talking about some of the newer agents that are coming forward, we've heard about the antibody Daratumumab, Darzalex, the antibody Isotoxumab. Now there's a trial with another antibody called Kalium 101. Do we need another antibody?
As I mentioned earlier, that's one of the unmet needs for amyloidosis treatment is having a fibril-directed agent that will help protect the organs or allow organs to recover faster or in conjunction with what we do with chemotherapy. And KAL101 is such an antibody. So this antibody targets amyloid fibrils and allows fibrils to be broken off and removed from organs and then cleared off by the body's immune system. So while it's also a monoclonal antibody, at the chemical level, it works very differently from Daratumumab and Isotoxumab.
So Daratumumab and cyclophosphamide, bortezomib, dexamethasone, Cyborg-D, that does not direct against the fibril?
No, chemotherapy in general works at the bone marrow level, and it targets the cells that make light chains that turn into amyloid fibrils. So in general, chemotherapy has no direct effect on amyloid fibrils. The way it allows organs to get better is indirectly by preventing new amyloid formation and deposition.
Okay. Has anybody seen the press release from Prothena regarding NeoD1, or now known as Daratumumab? Is anyone prepared to discuss that at all? It was not published. It's a press release only.
Yeah, I can mention it, Morie.
Thank you.
Yeah, so NeoD1 is again, a monoclonal antibody that's also targeting AL amyloid and fibrils. It was studied in 2 trials previously, one called VITAL, which was a large randomized trial of patients receiving upfront chemotherapy with Cyborg-D plus NeoD001 versus placebo, and also a trial called Pronto, I believe, which was a trial of people who were no longer being currently treated with a chemotherapy, who had a pre-existing amyloid in an organ. That trial was designed to look at cardiac biomarkers. Those 2 trials were ongoing simultaneously, and the VITAL trial actually completed its analysis and unfortunately did not show any significant effect of NeoD001 on cardiac biomarkers, which was kind of a surrogate. As we've been talking about, biomarkers usually indicate how the organ is functioning, and the hope was that the heart would get better, and it did not. Based on that result, the ongoing VITAL trial was subjected to what's called an interim analysis to try to see if the therapy would be effective in patients who were currently enrolled in the trial. My recollection is there were somewhere between 200 and 250 people enrolled in that trial at the time. And the Data and Safety Monitoring Board was asked by what's called the sponsor, the company, to check and see, because the VITAL trial didn't show an effect, because Pronto wasn't showing an effect, would VITAL show any efficacy? And essentially, there was a trend, but nothing statistically significant in the overall trial, such that there was no expectation that NEOD-001 would meet what we call its primary endpoint, that it would show to improve significantly heart outcomes in people with AL cardiac amyloidosis. So that trial was stopped prematurely. The company subsequently has done analyses of that data that they accrued, and they found out that in patients with advanced cardiac stage disease, quite surprisingly, there was a statistically significant effect of NEOD-001 favorably in patients who were newly diagnosed on mortality, such that those in the small subgroup who received NEOD-001, who had advanced cardiac amyloid, lived longer than those who did not receive NEOD-001. Accordingly, they've gone back. Pardon me?
This is specifically NT-proBNP between 1800 and 8500. So that is important for people to know. Muriel, is there anything you can add that would be not covered by any type of confidentiality agreement you may have with Prothena?
Is there something specific you're aiming for here?
I don't know. Where is something going to happen, do you think, with this NEOD?
It's public
well,
knowledge,
yeah.
I think, that now they have a agreement by the FDA to conduct a prospective trial, repeating the results of the subgroup that you described, Morie, in those between 1800 and 8500 who are newly diagnosed. And so
what will this trial be?
It will be a prospective randomized trial of people with advanced cardiac amyloid, newly diagnosed, who either receive NEOD-001 versus placebo. And I believe it's a 2-to-1 randomization to either active therapy versus placebo.
So unfortunately, this will be for untreated patients only.
Right. It will be treatment naive patients, as they say, newly diagnosed patients.
Yep.
They will get the standard of care, which is now Daratumumab and Cyborg-D. Everyone will get that, but 2/3 will also get the new NEOD name, which is Berta something, and 1/3 will get a placebo, but they will still get the treatment of Cyborg-D and Daratumumab.
No Daratumumab.
But they will it's important to know that number one, it's 2/3, which is really helpful for these patients. And also, I know that the patient, they want to make this really fast. I think the FDA gave them special permission to do this, and they want to do it fast. They said after a year, everyone will get the drug, the NEOD drug, which is important. So that's good to know. And they will be using stage 4 cardiac patients, which are the sicker group of patients, which were excluded in the previous trial, because those are the patients where they'll be able to show the FDA really quickly how well people do, hopefully, on the NEOD drug. So it hopefully will be done quickly, maybe even within 18 months. I think that's the hope.
Thank you. Dr. Paner, can you tell me about that medicine, Venetoclax or Venclexa or whatever the heck it's called, and where are we going with that medication in AL amyloidosis?
Right, so that is a very interesting medication. Venetoclax is BCL2 inhibitor. It has a particular activity in patients who plasma cells harbor genetic abnormality translocation 1114. So it's not your genetic abnormality, it's the abnormality of the cancer cell. And it happens that in amyloidosis, nearly half of the patients have translocation 1114. compared to multiple myeloma, where perhaps only 20% of patients have that translocation 11-14. And this drug, again, was initially studied in multiple myeloma. There was activity that was demonstrated particularly in patients with translocation 11-14. And now we are starting to see studies in AL amyloidosis. So in this particular ASH meeting, there was an abstract of a small number of patients who were treated with Venetoclax and also simvastatin, the drug that we don't really use for plasma cell disorders at all. But there was an interesting synergy. It seemed like it helped Venetoclax to work even better.
What's simvastatin?
Simvastatin is a medicine for cholesterol. So a lot of patients may know it or be on it already because they're taking it for their heart disease. So it's easy to repurpose drug. It's a pill that's added to regimen. And Venetoclax too is actually a pill. So an abstract that was presented in ASH meeting, 8 patients participated, 7 of them had translocation 11-14, and over half of them responded to the treatment. And half of those who responded had a very deep response, like very good partial response.
How common is this 11-14 translocation and amyloid?
I think it's about 40% of patients who have translocation 11-14. Please correct me if you have different numbers.
Close enough for the group. Muriel, so with your sheets that you hand out to patients that are so helpful to the doctors, that tracks the light chain and the biomarkers and the M spike and the urinary protein, I think you're going to need a checkbox now for 11-14, yes or no. That's going to be an important thing that we're going to want to know as patients come. And with all of these new things we've been talking about, all these new antibodies and pills and transplant questions, can you tell me, where do you currently stand, having been around the block, regarding getting a second opinion at diagnosis before treatment is initiated at an amyloid center? What is your take on this, given the fact that you can read about this anywhere?
My take on this is it's a lot harder than it used to be because we have a lot more centers and we have a lot more people that think they're centers now that we have the CyberD Darzalex approval. I think I saw someone yesterday do a post saying his general practitioner in some Midwestern state not only diagnosed him, which is super, but he also prescribed for him. So if that would immediately make him unable or to qualify for a trial for newly diagnosed treatment naive patients with either the Karam drug or the NeoD drug on those trials. So, but we are seeing that more and more, that the patients we are seeing are not newly diagnosed and they are being at least given their first treatment by their local center before they're heading to that center of excellence.
Thank you very much. In terms of, I just want to close in 5 minutes, and I was wondering if we could I want to ask each of the panelists where they think the current unmet needs are for amyloidosis. I'll start with Dr. Paner.
Well, thank you, Dr. Gertz. I think the more we learn about amyloidosis and how to treat it, the more questions arise. I think initially Andromeda study we discussed is really making us think again, what is the role of the transplant? And the role will still be there. We just have to there will be another slew of studies now to see when and who should be getting transplant. I think another interesting question is the maintenance therapy in amyloidosis, perhaps how we measure depth of the response, something like minimal residual disease. We haven't touched on that. And certainly organ improvement, the therapies that specifically target. So KL101 is, I think, very important drug to investigate in that space. And it's interesting, it will be interesting to see NeoD 001, what the results of those studies will be.
Thank you. We're going to actually try to hit MRD during the Q&A when we discuss goals of therapy. Professor Liedtke.
Yeah, that was a really good summary already. What I would add is something that I would really like is treatment for our high stage patients. I think we still struggle to treat patients with advanced cardiac disease, even with good light chain suppressive therapy. The outcome there is not as good as we would want it to be. And then the other main area of interest from my perspective is our inability to predict response and to predict toxicity. We know now that patients with an 11-14 translocation, for example, have a higher chance of responding to drugs like Venetoclax. But I think we need to make more effort to be able to predict how a patient will respond and what toxicity they will develop before we start therapy, so that we don't expose anyone to any treatment that's not going to be helpful, but it's rather going to be toxic.
Thank you. Professor Maurer.
Yeah, I would agree with what my colleagues say. Obviously, the patients with advanced cardiac amyloid have a huge unmet need. I think also our educational efforts for providers need to improve. They still, many of them believe, these are clinicians out there, that amyloidosis is very impossible to diagnose and has no treatment. And I think early diagnosis remains a huge unmet need.
Professor D'Souza.
Yeah, echo all the same comments from colleagues. I think early diagnosis, our patients tell us they go for years, sometimes see many specialists and subspecialists with all the symptoms of classic symptoms of amyloidosis. So I think diagnosing patients early is a huge unmet need. And then I would like to see how does transplant compare with, is it 2 years of Daratumumab for all newly diagnosed amyloidosis patients, or do we still try to get patients to transplant early and perhaps give a treatment-free period that transplant can provide? And I think it's time to revisit a transplant clinical trial in amyloidosis.
Professor Zonder.
So obviously everybody is, all the comments made are good ones. I think early cardiac disease has to be one of the top priorities. What we didn't touch on, but the Griffin study, I'm sorry, the Andromeda study, what it did not show was an improvement in 6-month survival with the addition of Dara. Patients still had, there was still early mortality, and again, that study excluded the patients who would be most at risk of that early mortality. And so these, I think these trials that we're doing right now, looking at antibodies or other therapies to reduce early cardiac risk, I think that's where we can make the biggest impact in patients. And then also the other group we have to focus on is the 20% or so of patients who still don't have a great light chain response, because like I said, no matter how you look at deep response in the Andromeda study, patients tended to do well. But no matter how you look at failure to meet one of those deep responses, patients didn't do nearly as well. And so there is a fairly sizable percentage of patients, even with best frontline therapy that includes a CD38 antibody, there's a significant number of patients who aren't going to do as well unless we can have some salvage regimens, whether it's transplants, whether it's an IMiD, whether it's Venetoclax, whether it's whatever, but it's some sort of salvage regimen that does successfully get them into that deep light chain response.
Thank you. Professor Karam, you've been remarkably patient during this hour as we focused on a meeting that you've probably never attended, but in terms of your practice with amyloid, with neurologic patients, what do you see as the current unmet need?
Yeah, I've been very impressed with all the data and learning a lot today. So thank you all for coming. And, from a neurologic perspective, we do have a decent amount of patients who present to the neurologist with neuropathy and eventually turn out to have amyloidosis. I think raising awareness among neurologists, what is the appropriate testing? A lot of neurologists don't screen for free light chain, for example. And then, once we increase and, knowing that carpal tunnel syndrome can also be one of the first signs of amyloidosis, dysautonomia with the orthostatic hypotension and constipation and diarrhea and so forth. All of these are common symptoms in amyloid, and they can present as a first sign of amyloidosis and present to the neurologist first. So the neurologists have a role in screening and making early diagnosis, because as we've been seeing, the earlier diagnosis is better. The second aspect from a neurological perspective is the nerve but damaged. So one, the chemotherapy that we're giving, thankfully with Dara, things are a little bit different. It's not as toxic as bortezomib to the nerve. Actually, it may not be toxic at all to the nerve, as much as the kind of older drugs that we're using. So that's good, because that is something that limits how much treatment you can give because of the neuropathy, and which can become disabling. The other thing that I hope that at some point we will focus on a little bit more is finding novel treatment for the pain and neuropathy. A lot of our patients suffer from peripheral neuropathy, and yes, they can live longer now, but we don't have great treatment for the pain and peripheral neuropathy. We're using a lot of different drugs, but a lot of time they're not very effective and have a lot of side effects. So hopefully we'll have more advances in that area. Thank you.
Thank you very much.